just start.
Okay, I think it's great to be able to get everyone together, and the stars of the show are all there. So I think we'll get it going. And it's awfully nice that David was able to agree to moderate this session. For those who know David, I'll just briefly introduce David. Tenoch, you might have met, and Carlos, you might have met David at the IFNE meeting in Nairobi. I know, Henry, you did. So
Yes, I did.
yeah. So David is one of our senior neurosurgeons in Kenya. He's also the secretary of the Neurological Society of Kenya, and been very active in fact, perchance, I might as well just mention that David is the first guy who did neuroendoscopy with a urethroscope in Kenya, and then led us into neuroendoscopy. So David, it's great that you are here to moderate this session. And of course, you've met some of our panelists before. So over to you. It's a pleasure on behalf of the World Federation to have this series. Just as a reminder, everyone, there's been brilliant neuroendoscopy courses being held, and the IFNE and Salman from Pakistan have been conducting some excellent webinars. And Henry did wonder whether we were duplicating, and then of course he agreed that we were not going to duplicate because this was focused on trainees and younger neurosurgeons who are learning about neuroendoscopy. So we'll temper it that way. And thanks again. And thanks, Martin of the World Federation, who is the IT brains behind the webinars for the WFNS. And he's organized it so well for us. So with that brief introduction, welcome to everyone. And over to you, David. There you go.
Thank you, Moody. And I say it's a pleasure for us to have this session this afternoon. And I think without further ado, Henry, before you start off, Henry told me that I had to make sure that I put in my my CV so that people know who I am. But Moody, as usual, being the one who leads and I follow, has managed to say who it is that I am. So Henry, it's indeed a privilege and a pleasure to ask you to talk to us this afternoon about endoscopy in surgery for colloid cysts. Over to you, Henry.
Okay, thank you, David and Moody, for the nice introduction. My topic is colloid cysts, but we just have six participants. Is it open for
all? I think, Henry, I'm not sure if we are seeing all the participants, but there are about 55 guys registered for this webinar, and we expect that some more will join at the last minute. Metin, do you know what's the situation?
No, anyhow, we can start. It's no problem. I just wonder. Okay, so hello, everybody. My topic today is endoscopy and surgery for colloid cysts. I think endoscopy is of great value when you deal with colloid cysts. And the appearance of the cyst in the ventricle and also the size of the ventricles, everything is very variable. So we have to plan our approach and technique according to the individual anatomy, individual situation. So I think there is not one fits all, but we have to choose our approaches. Is it microsurgery? Is it endoscopy? Which side we should come according to the individual anatomy. So it's a really a case-based decision. So what is an indication for surgery? I think everybody's agreeing that all symptomatic cysts are a clear indication, but also asymptomatic cysts, which cause already CSF pathway obstruction with ventricular dilation, and in our institution are also an indication to do surgery because it's only a matter of time when symptoms may occur. But we have also asymptomatic cysts without CSF pathway blockage, small cysts, usually in older people, and then we recommend observation. And I have patients in my follow-up for more than 10, 12 years, and the cyst is not growing at all. So it's not fair if the surgeon is telling the patient, oh, you have a time bomb in your brain, we need surgery, otherwise you will be dead soon. That is only to collect cases and it's not fair. But sudden death is a problem. And I made a literature research some years ago, and I found, especially in children, a very short history. Some patients complain of headache only for 24 hours, herniate and die. 6 years old, 6 years old, and 14 years old, even less than 1 day of symptoms. So when we have, especially younger patients, if you have a colloid cyst, we have CSF pathway obstruction, we are very aggressive in recommending surgery. In my institution, I saw 2 patients who herniated from a colloid cyst. This was a 19-year-old girl. She had a 4-month history of headache, and the doctor said it might be related to her period. And then suddenly she fall into coma, and when she come to us fixed dilated, you see the large cyst and this occlusive hydrocephalus. Another patient was a 30-year-old male. He had a 5-month history of headache. Then he had a car accident in the morning, but he was awake and had no obvious problems. And we recommended to him he should stay for observation for 1 day. But he left. And then 3 hours later, he came in because he had a seizure, headache, vomiting, and rapid deterioration. But he came too late. Also, hydrocephalus with acute occlusion of the foramen of Monro with herniation. So that might occur. That's why we should always be awake when we see colloid cysts, especially in young patients. So this was one patient. You see there is a cyst, small ventricles, only minor headaches, no nausea, nothing. So we recommended observation for him. And you see 4 years later, the cyst disappeared spontaneously. So this was a spontaneous rupture of the cyst. I have seen this in colloid cysts, in arachnoid cysts, in pineal cysts. So it may happen, but of course we cannot wait for spontaneous rupture. This is rare. This is Michael Powell from Great Britain. He was the guy who first used an endoscope for the resection of colloid cysts. So he incised it, opened it, and coagulated it. That was the beginning in 1983. When you look to the extent of resection in the initial publications, usually there is only a partial resection and capsule coagulation. And of course, when you leave some cyst part behind, there is a risk of recurrence. And Philip Deck stated in 1980 that by its nature, endoscopy cannot offer complete removal as compared to microsurgical technique. And Alan Cohen said the same, that usually is not a complete cyst removal possible. But is this correct? It's another study from Italy. They had 61 patients, also coagulation of the cyst wall and colloid aspiration of the content, and they also had 7 asymptomatic recurrences. So there is the risk of recurrence when you leave. But is a safe endoscopic total cyst resection possible? I think it is in many cases, but we have to adapt our technique for that. So the borehole is more anterolateral. We use sharp dissection, bimanual dissection, retraction with the endoscopic trocar, small chamber irrigation technique, and dry field technique for hemostasis. So this was the initial borehole for our first cases where we did endoscopic resection of colloid cyst. It was the same like for a colloid cyst, but you see, you have a tangential view to the cyst. You don't see to the attachment at the roof, but you look to the floor. So this is not a good idea. The better approach is you come more from anteriorly and laterally. We just slide over the head of the caudate nucleus. And then you have this view to the cyst much better. You can open it and we see the attachment to the telechoroidea. The only exception is when you have a cavum in the septum pellucidum, then you can use the Kocher's point to go into the cavum because the fornix cysts are usually separated, and then you can come from above, you cut the telechoredia, and you can very easily remove the cyst. Usually the foramen of Monroe are very narrow in these cases. So when you come from lateral, it's very difficult. You see, this is one example. The foramen of Monroe is small because the cyst is pushing the fornix cyst laterally. So it's better you open one layer of the septum pellucidum here, and then you are on top of the cyst. You see one fornix is here, and this is the other fornix, and you can just open it here. That is much easier. So when you use a ventriculoscope for colloid cyst resection, you need an endoscope with a large working channel. And that is very important. And for me also, it's important that I have an endoscopic sheath because I use it for retraction and also to create a small chamber in front of the endoscope. So we have an endoscope with a diameter of 6.1 millimeter, and this working channel has 2.9 millimeters. And you can use a thick suction tube to evacuate colloid cysts. That's why we prefer a scope with a larger working channel. We have this Chaillet 8 suction tube. It's a for pediatric suction tube for the anesthesiologist for kids. And the diameter is 2.7 millimeters. And we have a syringe to aspirate the content. Then I like to have the endoscope fixed with a mechanical holding arm. So far, in my opinion, the best is this pneumatic arm from Mitaka. You just press this golden button, then it's very easy to adjust it to the position where you want to have it. And of course, you need an HD camera because you want to have a very good quality image. This is a view into a craniopharyngioma, and you can even see erythrocytes running through the blood vessels. Such high resolution you can get when you go close enough with an endoscope. So our HD camera should be standard now. For hemostasis, we use a bipolar diathermic electrode, but also in bipolar forceps. And we have a technique which one of our fellows coined it as small chamber irrigation technique. That means if it starts to bleed, you don't see, we start irrigation, then we go close to the bleeding point with forced irrigation. And then we retract the endoscope into the sheath and create a small chamber. And this small chamber can be cleared with irrigation. If you want to clear the bleeding in the lateral ventricle, you have no chance because it's so much volume, you cannot get a good view. But if you have this small chamber in front of you and you go close with this margin of the endoscopic sheath to the bleeding source, it bleeds only in this area into the small chamber, and you can irrigate it very easily with irrigation. And then you can make hemostasis by coagulation. So one example, you see, this is a bimanual technique. We pull on the colloid cyst, and we have an electrode here. There's a small artery from the telechoredia, which is very adherent to the cyst. So I want to coagulate it. I coagulate it 3-4 times. And I hoped that the artery is occluded. And then I take scissors, cut it, and you see, oops, not good coagulation. Starts to bleed and you don't see very well. So then we start with irrigation to get a good view. If you have a microsurgical technique and you have this small bleeding, it's nothing. You even don't recognize it, but because of the magnification with an endoscope, and especially because we work underwater, it's a problem. So now you see I go back with my endoscope into the endoscopic sheath and I create a small chamber. And then I use the endoscopic sheath as a retractor. So I go into the foramen of Monroe. You see here's a margin. Then I retract the fornix a little bit, and now I have access to the telechoredia where the small artery is. So the small artery will not stop spontaneous with irrigation, or at least it takes a long, long time. So it's better you make a good coagulation that you have no problems. So small chamber irrigation technique is good because you can clear the view in front of your endoscope. And then you can continue with the surgery of the cyst. Dry field technique is another technique when you have a hemorrhage. We use it always when we cannot control the hemorrhage with simple irrigation and coagulation. We published this first time in 2002 in the first paper of colloid cysts. And then Joachim Oertel from Hamburg, he summarized 6 cases where we use this also. It's a very, very helpful technique Very easy. I show you one example. This was a colloid cyst. And one of my guys should hold the endoscopic forceps and I should rotate it, but he pulled too much and you see severe venous hemorrhage. And when you see that view, the Japanese flag, you know, with irrigation, it will not work. So then very early we changed to dry field technique and we use a suction catheter to carefully suck off the bloody CSF. You have to be careful that you don't suck on the fornix. Carefully suction with this catheter. And then we remove all CSF from the lateral ventricle. And in all cases where we use this technique, the bleeding stopped spontaneously. So we had not identified the bleeding source. I coagulate here, but this is a clot. It's nonsense to coagulate. This is just a clot. The bleeding source stopped just from removing of the water from the ventricle. So then we can usually we refill the space after hemostasis has been achieved because the ventricles collapse when you remove the CSF and the room becomes small, and also the bipolar coagulation, what we use is only working underwater. But you see there's no damage to the fornix. You can, even if you see is a disastrous hemorrhage, you can deal with it without change to microsurgery or without to abortion of the procedure. Then we have a flexible forceps because we like to have a bimanual technique for dissection. So I introduce the flexible forceps via the side channel and then the main instrument via the main channel. And that is very helpful because I can lift up the cyst and then I can cut, and I have no risk that I cut into the structures below the cyst. That positioning is almost neutral. That should be almost the highest point. And then we go far laterally, about 5 centimeter lateral and 4 to 5 centimeter in front of the coronal suture. Sometimes the best point would be here in the forehead, but for cosmetic reasons, we place it behind the hairline, or in bold heads, like here, we use a wrinkle to go in. Navigation is used in all of the cases to find the ideal trajectory to the cyst, and this is our setup in the operation room. One example, you see there's a cyst, typical colloid cyst. It's not too dark in T2. It's a good sign. It's iso-intense to the brain. And you see on the left side, there's ventricular dilation. So it's a unilateral CSF pathway blockage at the foramen of Monroe. Then, of course, when you ask which side should the approach, you see the cyst comes here. It's very apparent in the foramen on the left side. The ventricle is large on the left side. And of course, we come from the left side. Navigation is used. We come from an anterior borehole. We just slide over the head of the choroid nucleus. And you see, this is an ideal case. That is my easiest colloid cyst. It's not covered by choral plexus. White ventricle, you go in, you open the cyst, and you see the content is easily suckable when you use a large suction tube. And you see it almost surrenders spontaneously by irrigation. Of course, it's still fixed to the telachoroidea. So we coagulate a little bit of the plexus. Then we take one forceps, lift it up. This is a forceps via the side channel. And then the second forceps come to the main channel. And usually you see here in the pedicle of the cyst vessels, and you have to use coagulation. But you see, in this case, the pedicle is just a fibrous band. It's not a single vessel inside. And then you can use scissors to cut it, or in this case, it just ruptures the small phylum, which is attached to the cyst, and the cyst is then removed. This is, of course, the ideal case, but this is the only one I have. Maybe Chandra has more, but I have never seen, again, such an easy cyst removal. It's another case. You see the content is a little bit more dark in T2. Both ventricles are of equal size. the foramen is apparent on both sides equally, then we usually come from the right side, because in the left-handed people, in the right-handed people, it's the non-dominant hemisphere. So here the right-sided approach is chosen. You see this is a fornix, choroid cyst, septal vein, choroid plexus. This is thalamus striate vein. So this must not be injured. So we coagulate the plexus, we cut the cyst wall, and then we use the aspiration. And you see it's not so easy to aspirate because the content is more firm. And then we mobilize the cyst into the lateral ventricle to get access to the pedicle. And sometimes the pedicle is short and sometimes it's long, so it's very variable. So again, we try to aspirate, but the contents here is almost calcified. It's not so easy. Then we take a forceps and we grasp the cyst. You see, this is a cyst membrane. It's very thin. All other tissue around is nothing, has nothing to do with the cyst. It's just telechoroidea. By manual technique, coagulation of the plexus on the contralateral side. And now I use this endoscopic sheath to push the cyst up in front of the septum to get access here, coagulation of the plexus. Be careful, this vein should not be closed. Then I use scissors to cut it. And you see, oops, too early. Still a vessel in the choroid plexus, which caused problem. And then initially I tried to coagulate, but in the depths when you don't see, you don't want to coagulate. That's why I again use the dry field technique. Removes the CSF from the lateral ventricle, bleeding stopped. And then again, the cyst is mobilized. And you see, this is only the cyst membrane. All other tissue around is the telechoroidea. So I refill the ventricle to get more space. And you see, this is the pedicle of the cyst. This is the pedicle. And now this pedicle is very long in this cyst. So I push the cyst up with my endoscopic sheath over the septum pellucidum. And then I have ideal control. I see exactly where the telechoroidea, can coagulate it and cut it without damaging the fornix. But you see here, the cyst is not fitting through the whole endoscopic sheath, so I have to remove the whole system to bring the colloid cyst out. So if the content is black on T2, it's usually firm. So with a 45-degree endoscope, we check whether the cyst is completely removed or not. And you see there's only very superficial ependymal damage. The fornix is completely intact. Patient had no problems after surgery and is a gross total resection. So should we always aim to total resection? I think not always. This was a patient with a huge colloid cyst. And you see the fornix is like paper. It's paper, thinned, and running over the capsule. So in this case, I made a wide septostomy. I opened the cyst, I evacuated the cyst, and on the contralateral side, I make another wide septostomy. But I did not take all of the cyst because I was afraid of the fornix. And you see, this is 3 years after surgery. The fornix has reshaped, and he had a really a tremendous improvement of his memory function. But after 3 years, I lost to follow up him. That is unfortunate, but I don't know where he's now. Always endoscopic surgery. This was a patient. He had an endoscopic attempt at another institution on the left side, and they left a catheter inside. And when I looked to this, I said, no, it should be possible because it does not look too bad. We make a cyst sequence and you see, wow, this should be cyst. Here's a fornix. That should be an easy case. And then we looked in, and I understand because why they gave up the surgery, because you see, the fornix is covering all the cysts. There is no open foramen, and this was created by the tip of the catheter which they put after surgery. So when I saw this, I said endoscopy is not a good option. I switched to microsurgery. I opened the septum and took it from the midline. She had initially more memory problems, but this improved after 1 year. But there was a lot of manipulation to the fornix, of course, in this case. So another patient came to me. Also, he presented with memory problems. And you see white ventricles. And you see here is a small cavum. This cavum usually shows that there is a separation of the two fornices. And you see, this is a vein over the foramen. So the foramen is here very small. On the left side, almost close, but on the right side, very small, because this should all be fornix. That's why I said to him, in this case, I would prefer microsurgery, and he has white ventricles. So we go in with the endoscope, look at this area, and then we use this translucent endoscopic, translucent sheath, a small tube, to follow the track of the endoscope. You see, when you look in, you see this is all fornix. This is a cyst, bulging it. Of course, you could use an endoscope and open it here, but in my hands, I think it's less traumatic when I have a little bit more working space. So I remove the endoscope, bring this tube in by following the tract. You see, this is all cyst. This is septal vein, and you see the fornix, the foramen is very small. So I switch to microsurgery via this tube. I make an interforniceal dissection. This is one fornix on the left side, one fornix on the right side. You see the content is very firm. So with an endoscopic technique, it will be very cumbersome to remove this big cyst. This is internal cerebral veins. The telechoidea is dissected. And you see this is, again, this is very thin membrane of the cyst wall. All around is just telechoidea. This is a pedicle, choral plexus, is coagulated and cut, and then removed. So I think with a bimanual technique, via the tube, you can better preserve the fornix. So if you make an interforniceal dissection, I think it's more protective because I have a small patty. This is after resection. You see the fornix here on the side is completely intact, and the left side as well. And he did not deteriorate after surgery in memory function. It's another patient. You see, he comes with a cyclops ventricle. The septum is gone completely. And you see here, this is fornix. And if you look, there is no interforniceal indentation or so. When you go here straight through this fornix, I think this might be a problem. If you look to this T2 weighted image, you see most of the content seems to be very liquid, and only a small piece seems to be firm. So in this case, I go not transcallosal. Transcallosal I use when the ventricles are small, but here again, I came in with the endoscope. I have a look here, and then again, I go in with this, with the tube. You see, this is fornix. There is no good separation plane between the two fornixes, and I think we will damage them if we go in. Foramen is very small. It's just a millimeter here. It's just a millimeter space. So with an endoscopic technique, I think I have two manipulations too much. So I go in with this tube, just following the endoscope tract. And then I can dilate the foramen a little bit with two forceps, have better access to the cyst. I have shaft instruments to cut. And you see this content is very liquid. Comes out easily, easy decompression of the cyst. And then I can use both forceps to dissect in the right plane. You have to grasp the right plane. Don't grasp the telechoidea, but try to go directly to the cyst, which is sometimes difficult because it's hidden. But then if you see this plane, the capsule comes out very easily. And the only thing what is remaining is here the pedicle. And then I can use scissors to cut the pedicle, called plexus on the other side, coagulation, cutting, and then the cyst can be removed. And the final inspection shows there's almost no damage to the fornix, optic chiasm. And looking backwards to the posterior part of the third ventricle, make sure there's no blood clot and there's no remnant. And then this tube is removed. And then I close the corticotomy with fibrin glue to avoid that there is subdural collection of CSF. And this is after surgery, and he's also doing well. So we have published our initial experience of 20 patients in the long-term follow-up, and we had 3 patients where we had to leave remnants, and in 2 of them we have a recurrence. And now we just, this year we published in our bimanual technique with sharp dissection, and we have a good gross total resection rate. There were 16 patients, all had problems except 1 was asymptomatic. And we had 4 venous hemorrhages, all could be controlled with a dry field technique. And we had 1 patient who presented already with memory problems. And she stated that she deteriorated further on in the course. I'm not sure whether she has really memory problems from the colloid cyst because the ventricles were not very dilated, or she has maybe an Alzheimer's disease or something else. There was no mortality. We had just to leave in 1 patient a little piece of membrane because she requested the least risky surgery, and it was an old lady over 76 years old. Otherwise, we were able to remove the cyst completely with a bimanual sharp dissection technique, and so far we have no recurrence. So the conclusion is that in most of the colloid cysts, we can have a gross total resection with an endoscopic technique, and we should be as radical as possible to prevent recurrence. But if you have a problem to get a good resection, I think it's no problem to change to microsurgery to solve the case. Thank you for your attention. So I want to invite you to our endoscopy course, what we had in Greifswald, but because of COVID, we could not do it this year, hopefully next year, maybe in 21. Thanks for your attention.
Thank you, Henry. That was very enthralling. I think seeing you doing the bimanual technique and with those sharp instruments and how you're able to do the dry field and the small chamber, I was putting myself in that position. If I had that amount of bleeding, I think I'd want to go for a small room break, but that's very, very, very clear. And I think it's good to see our master at work and that all these things are possible. There's just seeing if there are any questions at the moment. Meanwhile, while you're looking for the questions, there's somebody, Raja KR asked, could you elaborate the steps of dry field technique, like stop irrigation and then aspirate? That's a question from Raj.
Yeah, I just stop irrigation and then I take the suction tube, what I have, and slowly I remove the CSF. You have to be careful. If you go too deep and you don't see well, you end up at the fornix, and you should not aspirate on the fornix. So we had the problem with Chandra in India. Do you remember? We had no suction tube, so I had to suck from the working channel directly. Working channel, yes. That is not good because then it's dangerous because you suck the fornix. But if you take the tube, you can go slowly down and remove it very in a controlled fashion.
Okay, Chandra, you said you I know you as you're busy swallowing your lunch. Was it breakfast?
Well, I just arrived, so I was offered a cup of tea and I couldn't resist.
Any time is cha time. So I think any comments on that?
I think what Henry has accomplished, I think it's remarkable. And especially with the use of the dry field technique, and I have had an opportunity to watch him operate a couple of colloid cysts already. It's really remarkable how easy he makes it look. I have personally not found it as easy a procedure as I must say. One of the reasons for that is probably having a scope like the HD LOTA scope, because of the fact that you can do a bimanual dissection, you can really do such a good surgery. Otherwise, at the level of the venous angle, and especially with a colloid cyst, which is virtually wrapped by both the choroid plexuses on your side as well as the opposite side, it can get quite tedious and it can really get very difficult. So I think apart from the technique which he has described, it is also important that you should have a LOTA or probably Earlier, there used to be a deck scope, but it was too long and too difficult to handle. We have had a deck scope in our OR for some time, and I have found it difficult to use as well, uh, mainly because of its long length. I think it is very important that you have proper equipment, and I think we have used hemostasis. Achieving hemostasis probably may be easier with thulium laser now if you have available. I don't know if Henry has any experience, but especially we have found in a vascular tumor and sometimes in arachnoid cysts, etc. It has been very useful. So it's an elegant technique, but I think you need to learn it well and you need to know your limitations.
Thank you. Henry, what you're using was a LOTA, and then did you have to use a little one as well, or just a LOTA throughout?
No, for the little LOTA, the working channel is too small. You cannot use it for colloid cysts. This will not work. Even if it's a liquid content, the suction tube is too small. I think this is also the reason some people give up, because they say it's not effective, because if you have this firm content and you need a grasping forceps, it takes hours to remove it. And when I see this huge cyst, black content, then I go to microsurgery. So this should be really a case-based decision. What is the best approach? It's not always endoscopy, in my opinion.
Okay, and then the tube that you use as a retractor, that's just a standard tube. What do you call that tube that you used when you're using a microsurgery?
You mean the endoscopic sheath or the tube which I use for microsurgery?
The tube.
The tube, yes. This is the side view. This is from, I think the company is Vigon or so. One moment.
You can actually use any sheath. You can use something like a feeding endotracheal tube. Sorry, not endotracheal, feeding gastric tube.
Yeah.
The only difference is that you have the hole on the side over there, which can be actually a good thing for you.
Yeah.
Okay.
Yes, Henry, you were saying.
Yeah, I thought I have a package here of one of these, but I have not. I think it's Vigon, it's a company or so. The side view is a name, side view.
Excellent.
That's very good because.
And there was a feeling. No, there was a feeling that if you see the dark titubated cyst, it may not be worth attempting, endoscopic removal. But I think you have shown that it is not always true. You have always given a first chance to that before you convert it to the microscopic surgery. I think that's also very important, which also means that you need to make a slightly bigger opening in the beginning rather than making just a small burr hole. It may be a good idea to do a very small craniotomy.
Yeah, but usually in these cases, what I showed you, I told the patient from the beginning that this will probably be a microsurgical case. Because from the MRI imaging, you have seen already, and you have an impression, how is the situation. And then I think if you want, of course, you can open the telechoredia to enlarge the foramen of Monroe endoscopically. But if everything is so tight together, I think it's much easier done microsurgically, because you have a peddy, you can displace the fornix to one side, and then you can open it much easier, in my opinion. Yeah.
Henry, just to confirm, is this a 12-degree or a 0-degree endoscope that you use?
6 degree. The LOTA has a 6-degree angled endoscope.
Okay, what's the advantage over the 12? Is it?
You can see earlier your instruments. So in US, there are many surgeons, they use 30-degree endoscopes. Yes. So they like to see very early when your instrument is coming out, and they can look a little bit around the structures. So I think in New York, Mark Suvedane and also other guys, they prefer 30-degree endoscopes. I have tried it, but I don't like it so much because you don't see really in front of you if you introduce the instrument. I think it's a matter of training. If you used to have a 30-degree, you see your instruments coming out very early, very close. But
so it's a good compromise between 0 and 30, I suppose.
Yeah.
Okay, excellent. Mohammed El Beltagi from Egypt. You're next up, sir.
Yes.
You are going to tell us about endoscopy for tumor biopsy. I hope the water coming down the Nile is not too much. You know, Khartoum, it is full, it is flooding. Lake Victoria is flooding. In Egypt, you're not flooding, are you?
No, not yet.
Okay, Mohammed.
Yeah, okay, David, thank you. And thanks, Chandra, for this opportunity. And can you see my screen?
Yes, very clear.
Yes, we can see.
Okay, great. So that's the topic Chandra's chosen for me, and I'm going to focus on children's mainly. Most of these cases were children, endoscopy for tumor biopsy. To start with, when you introduce your endoscope into the ventricle, you need to know the anatomy as trainees. This is the foramen of Monro, and that's the septal vein here. That's the fornices. Getting into the foramen of Monro, you can see the two mammillary bodies and the floor of third ventricle and the infundibular recess. That's infundibular recess, floor of third ventricle, and two mammillary bodies. And then performing again ventriculostomy, going there, you see the floor. There are different floors. Here you can see a transparent floor where you can see the basilar and the perforators underneath. And you can easily choose the point where you do your ventriculostomy and dilate it after that. See the membranes, iliquist, and if there is any adhesions that could be cut to ensure that's the basilar, the bifurcation, and the brain stem. Basilar tree, the posterior cerebrals and bifurcation of the basilar. Further cutting the membrane of Lilliquist to go more down, the clivus, the basilar artery, the two posterior cerebrals, and the perforators coming to the brain stem. Looking backward, you can see the aqueduct, cerebral aqueduct. All this with the 3 degrees endoscope, a gap one, and you can see the cerebral aqueduct and tumor bulging from the pioneer region into the aqueduct, which closes partially the aqueduct. We should get oriented about the anatomy first, and then what about the tumors which could be amenable for biopsies using these endoscopes? The tumor could be in the body of the lateral ventricle, in the frontal horn, or in the occipital horn, as you can see in the temporal horn. These are different sites for lateral ventricle, but about third ventricle, tumor could be as here at the foramen of Monro, at the colloid cyst which Henry showed, the floor of the third ventricle and suprasellar areas, or in the pineal region like this one. These are the tumors, and all are encircled, as you can see, by the internal cerebral vein and the venous system of the pineal. So when we target surgery for doing surgery for biopsy from the ventricular tumors, we need to know that using the endoscopy, we have minimal disturbance of the normal anatomy. We just go with the endoscope into the ventricle. We get a very good, adequate and tumor exposure, and we can then get our biopsy. Even more, we can do some tumor resections. And at the same time, we can manage the CSF dynamics and the hydrocephalus by ventriculostomy, as I have shown. Using a rigid ventriculoscope, fiber optic, a navigation would be of great help to ensure your directions and make sure that you're taking the biopsy from the right side. And sometimes we use an intraoperative ultrasound to identify the ventricle if you don't have a navigation. The types of endoscopic surgeries, usually either we use a pure endoscopy, you doing the biopsy, or third ventriculostomy and biopsy. Sometimes we need to do a septostomy when there is no communication between the two lateral ventricles. We need to do a septostomy and place a shunt. Sometimes cystic fenestration or Ommaya insertion, and some tumor small excisions. Endoscopic assisted is also feasible. So to start with endoscopic biopsy, first a third ventriculostomy and biopsy. When we choose to do a third ventriculostomy and biopsy, we can do a two-trajectory approach, one just at the foramen of Monro for the third ventriculostomy and one 3 centimeters in front to get the biopsy. But I prefer doing this with a single trajectory approach in between the two burr holes. So we can go 2 centimeters in front of our normal Kocher burr hole, where we can adjust the endoscope without pulling on the fornix and do the ventriculostomy and at the same time taking the biopsy. Also, using the navigation could assist you very easily, if you have it, to choose the burr hole that is most feasible to do both ventriculostomy and tumor biopsy. This is an 8-year-old male patient presented with headache and vomiting, and we had an immediate ETV and biopsy from this lesion. That's the video. We went the same ventriculoscope. That's the floor of the third ventricle, doing first the ventriculostomy before the biopsy, because this is a definitive treatment which is important for life saving. If we start with the biopsy, sometimes there is hemorrhage and you cannot do the ventriculostomy. So I prefer doing the ventriculostomy first, widening it by a balloon, as you can make sure that these pulsations are present, which means that this ventriculostomy is well functioning. Make sure that there is no adhesions below, and then going back, rotating the endoscope, you can see this is the aqueduct, and that's the tumor with a minimal calcification. This is a spot diagnosis of a germinoma. You know, the oncologists need a biopsy to start radiation. So we took enough biopsies should be taken. This minor hemorrhage by irrigation stops alone without any coagulation used. And then make sure back that your ventriculostomy is still working and not closed by any blood clots. And that's the post-irradiation of the patient who just needed a ventriculostomy and a biopsy with complete tumor resolving. This is another 4-year-old male patient whose complaint was headache and Parino syndrome. He was shunted outside our hospital, but fortunately, there was enough space to go. Again, the shunt was draining one side. So we went with the endoscope. That's the tumor. You see, that's the floor again, doing the ventriculostomy first, enlarging it, making sure that there are no adhesions below, and basilar perforators, posterior cerebrals, in, then backward, taking multiple biopsies from the tumor. This was a big one. You can see some hemorrhage that stops by irrigation and proved to be a germinoma. What about endoscopic biopsy for intrinsic hypothalamic masses? Like this one was a 10-year-old female patient who presented with diabetes insipidus, visual affection, and inconclusive open biopsy was performed outside the hospital. We revised the pathology several times and no conclusion was reached. Then I needed to go by endoscopy to see what is going on. We went inside. You can see the foramen is too small. Getting into the foramen, using the navigation here was very helpful to identify that this is the lesion of choice. I just introduced the probe of the navigation that is used for shuntoscope, for shunt insertion from the Medtronic type, to make sure that this is the lesion. And then I start taking some biopsies from this rubbery strange lesion. Again, irrigation for this hemorrhage is more than enough. You just irrigate with saline and wait until it stops. No need for coagulation. Multiple biopsies were taken. And this was proved to be a disseminated juvenile xanthogranuloma Erdheim-Chester disease with tuberous sclerosis, which is a very rare pathology. And that's why the initial open biopsy done outside was not conclusive. So biopsy and septostomy in case of a third ventricular tumor and chiasm lesions. When we decide to do a septostomy, this is a lesion in the middle that you will need to insert a shunt that is communicating both sides. So we will go further lateral from the normal burr hole in order to get the septostomy and the same biopsy. So navigation again is helpful. If not, you can go further lateral to the normal cochlear burr hole. This is one case with a chiasmal glioma. You can see the foramen is occluded completely with the tumor. Started doing the septostomy, looking for the thinnest part of the septum, pulsating, and then doing the septostomy with a bipolar coagulation, and then widening it. Further widening it with the coagulation and going inside the opposite ventricle. You can see the tumor again from the opposite side, including the both foramen of Monro, where in such cases, septostomy is needed. This is a 3-year-old female, right abducens palsy. That's the imaging. And you can see that there is differential between two lateral ventricles. We enter from the left side by rigid endoscope. That's the tumor. Foramen of Monro completely occluded. After doing a septostomy, we start taking biopsies from this lesion for pathology. Sometimes using the CUSA, the sonogram CUSA, is very helpful in debulking the lesion, but it will take longer time. And in case of a chiasmal glioma, this proved to be a pilocytic astrocytoma. We started after that chemotherapy because the vision was preserved on both sides. So multiple biopsies, and again, this minimal hemorrhage is stopped by irrigation. There are some cases where we need to do a tumor cyst fenestration and insert an omaya, and these certain cases like craniopharyngiomas, which are completely cystic and there is no solid part, so we just do a cochlear burr hole, go inside like this. This is a craniopharyngioma cyst, puncturing the cyst, aspirating the fluid, and then taking multiple punches from the cyst wall and endoscopically assisted insertion of an Maya reservoir. You can see that such a case is completely cystic. There is even no solid part, and that's the follow-up. That's the MRI, completely cyst, where we can start later on interferon injection. This is another case. Again, puncturing the cyst. This case was shunted outside and referred to us. Start by multiple biopsies, removing the wall of the cyst. I did here an extraventriculostomy after opening the whole cyst. Make sure the ventriculostomy is working. And then he inserted an omaya, and I did a septostomy. That's the shunt, which was removed later. And then the insertion of omaya, same way. So there are some pure endoscopic resection of tumors or excisional biopsies that could be performed in certain small tumors like this 6 months female patient who presented with headache, and the MRI showed this third ventricular tumor. Of course, it looks like a choroid plexus papilloma, that there was a shunt also inserted outside and referred to our hospital, where I decided to do a mini craniotomy, did an ultrasound, identify by the ultrasound the tumor. As you can see at the foramen, it's the lateral ventricle, and that's the tumor at the foramen of monoro. Another duplex to identify the pedicle. We found that the pedicle is exactly at the foramen and above here. So this is amenable. We can just introduce the trocar of the endoscope, as you can see under ultrasound guidance. You can see the trocar introduced and stopping exactly before touching the foramen. And here is the view. We know where is the pedicle from the beginning and start coagulating the whole pedicle and sharply dissecting it. This is, since it's a 6 months old female, so there was no possibility to have any blood loss. That's why I did a mini craniotomy in case we needed to extend to microsurgery. But fortunately, we were able to remove the whole tumor through the endoscope and then check back and do a ventriculostomy and remove the shunt. And that's post-operative ultrasound. Again, the foramen is open, the tumor removed, the 2 lateral ventricles. And that's the post-operative MRI. Also, you can use this for just inspection to get an idea about the tumor, the pedicle. This is a 5-year same picture, but we did here during the microsurgery, just inserting the endoscope to see where the pedicle is. There was no ultrasound available at this time, and turning around, start coagulate the tumor all around, which made it easy during the microsurgery, and also inspecting where the pedicle is, and then going microsurgically to remove the tumor. In such case, the tumor was just bloodless and removed completely from this mini craniotomy without any blood loss, and that's the follow-up. So there are limitations for such pure neuroendoscopic tumor resection. Not usually you can resect the tumor, but sometimes just a biopsy. This depends on the size of the ventricle. There are solid masses greater than 2 centimeters. Don't think about removing totally if it's vascular, especially in children. Tumors with considerable vascularity are also less amenable for any endoscopic resection, just small biopsies. The presence of a cystic component was always associated in this publication with a significantly lower complication rate when compared to non-cystic tumors. This was also helpful to get Ommaya insertion and interferon in case of completely cystic cranios that are young age, and you need to preserve the growth hormone and not start with radiation therapy or surgical excision of the cyst. But complete resection to be significantly more common for tumors less than or equal to 2 centimeters and with large cyst. So neuroendoscopic resection appears to be most safe and effective when applied in particular population with certain tumor morphology. It's often suggested to be applied for small tumors that are ideal candidates for endoscopic resection. Otherwise, an endoscopic biopsy should be applied for chiasmal tumor and germinomas, which are radiosensitive. Tumors like the supracellular hypothalamic that we need to know the pathology, all these for neuroendoscopic biopsy. So this offers a very good chance for intraventricular tumor insertion, where you can choose whether to endoscopically, or you can just proceed for microsurgery, or just go and the section where it's located. Neuroendoscopic approach to intraventricular pathology offered you an opportunity always to treat associated hydrocephalus concomitantly by inserting a shunt endoscopical septostomy or doing a ventriculostomy. But still, the microsurgical resection would be a gold standard for intraventricular large tumors which need resection. Thank you.
Thank you, Mohammed. That was very clear. And I think what is encouraging is when you are going ahead to do the biopsy, the ones which are amenable for resection, you just go a little bit more. I can see you didn't have the array of the instruments that that Henry has, but you are still able to get quite far ahead in terms of getting things done. So, but that's thank you for that. Comments?
Yeah, I want to make a comment. Mohammed, thanks for this nice presentation. I think it's very important that you pointed out that the biopsy and ETV can be performed by a one borehole. If the foramen of Monro is of adequate size, then it's possible. So everybody has to look very precisely at the images before he starts surgery, because I have seen people, they try to make an aqueductoplasty and an ETV, and the foramen of Monro is very tiny. And of course, then you destroy the fornix. And it's called minimally invasive surgery, but it can really cause a lot of disasters if you are not very careful with your indications and of your technique. That is very important for the young people who listen today.
Moody, you had something you wanted to say, Moody?
Moody, you must.
You are muted.
Right. Yeah. No, thank you very much, Mohammed. I think that was very clear. I just wanted to share with David and the group that is listening from particularly Africa, that Mohammed and a colleague from South Africa have started the initiative of promoting a separate section of the Continental Association in pediatric neurosurgery. So I think having somebody with Mohammed's experience and initiative is going to be very valuable to our societies, particularly in Africa. But I think this is a global setting. So just wanted to introduce that when Mohammed goes out to collaborate with other pediatric neurosurgical societies, they know that he has the blessings of the whole continental society. Thank you very much, Mohammed, for that initiative.
Thank you, Moody. Thanks for the support, and looking forward to collaborate with all Africa to promote the pediatric section in the CANS with the help of our colleagues from everywhere, like Henry, of course. We need them.
Absolutely. I think it's very useful
you have covered the whole gamut of procedures that can be done through the endoscopy, and the various observations you made are extremely important. There's just one extra benefit you can get of an endoscopic inspection. In certain patients, what is not clearly seen on MRI can also be seen. Mainly the tumor seedlings can be seen. And this is particularly very, very classically seen in germinomas. You get a lot of ependymal, subependymal nodules, and that helps you in probably staging the disease a little better and understanding the disease potential for CSF seedling. So I think it is of course become a very accepted procedure now, and your point is also well taken, that as and when possible, if you are thinking of converting it into a tumor resection module, you need to again do a small craniotomy and probably use either a tube, or you can do it with conventional retractors as well, but using a tube may be very, very useful. Thanks, Mohammed.
Thank you, Chandra. Thank you.
Samer had something to say. Are you there, Samer? I saw a comment, but I think he's probably not directly joined us. Unable to use voice, he says.
Unable to use
So
voice.
this is one problem with our system right now. Everybody cannot speak, and we have to make some further improvement in that.
No, but somebody's comment was excellent lectures. Thank you. And he cannot use voice, as you said. You're quite right.
Maybe while we've got Metin on the line, Metin, is it possible from your end to unmute attendees if they are wanting or wishing to make a comment, or we would like them to comment? Metin, are you there? I suppose Chandra will take this discussion offline with Metin and see how best we can do that. Go ahead. All yours, David.
Thanks, Moody. We'll go across to Argentina. Carlos Gagliardi. I think you are the earliest in terms of timing.
Thank you.
So we say buenos días. ¿Cómo está?
Good morning for all of you.
Thank you so much for joining us.
Thanks for the opportunity to show my experience in neuroendoscopy. I will talk about the management of tumor-related hydrocephalus. The neuro-oncological application of neuroendoscopy is tumor biopsy, endoscopic resection when it's possible, management of secondary hydrocephalus, and sometimes special techniques that we will talk in some minutes. According with this very important group of colleagues, the ideal tumor to be completely resected with endoscopic techniques has moderate vascularization, soft consistency, small diameter, associated with hydrocephalus, low malignancy, and located in the lateral ventricles. 4% of intracranial neoplasms are located in the ventricular system, 50 to 60% located in the fourth ventricle, especially in the infants, 25 to 30 in lateral ventricles, and 10 to 25 in the third ventricle. There are not difference between sexes and are more frequent in the first decade of life. The endoscopic management, according to localization and the endoscopic anatomy of the ventricular system, depends on your endoscopic equipment, your approach and surgical target, and the anatomical variation of the patients. If you use flexible endoscopes or rigid endoscopes, will be different experience, because with flexible endoscopes, even when you have thinner endoscope and less instruments, you can approach from one side more places in the ventricular system. The advantage of rigid endoscope is the quality of vision compared with flexible endoscopes. This image is not actual nowadays. The quality of image of the flexible endoscope has improved. The anterior ventricular approach, for third ventriculostomy, we use 1 inch behind the coronal and 1 inch from the midline. If you must approach the foramen Monro, the colloid, you go more lateral, and if you have to go to the rear part of the third ventricle, you go 5 centimeters from the coronal suture. This is that you will see in the frontal horn, no choric plexus, and the foramen Monro. This is the body of lateral ventricle and the posterior third ventricle with this approach. The posterior approaches, this is cadaveric, this is live. And even you can approach the fourth ventricle via a transaqueductal approach in special cases, not in all the patients. Perhaps with this approach is better with flexible endoscopes. If you have a tumor in the lateral ventricle, you will have a univentricular hydrocephalus. If the obstruction is in foramen Monro or anterior third ventricle, you will have a biventricular hydrocephalus. If the obstruction is in the posterior part of third ventricle, you will have a triventricular hydrocephalus. And if the obstruction is in the fourth ventricle or in the cisterna magna, you will have a tetraventricular obstructive hydrocephalus. You can use different techniques: freehand, stereotactical guided, neuronavigation, and ultrasound guided endoscopy. The tactic depends of the tumor. The ideal is total removal. You can make partial removal, biopsy, management of hydrocephalus, making a shunt from the ventricle to the cisterns, and special treatments. This I will show some cases. We have the opportunity to operate. This is a male of 75 years old with progressive hemiparesis, history of stroke, and 2 negative attempts of open biopsy of this lesion. At this moment, the patient began with hydrocephalus, so we made a third ventriculostomy and tumor biopsy. Enlarging the ventriculostomy. Inspection of the system is okay. And then we go to make the tumor biopsy in the lateral ventricle. We inspect the wall of the ventricle and we see this image that is pathological, and there we take the biopsy. The biopsy revealed there was a glioblastoma, and the patient in a very poor neurological condition was treated with oncological treatment, no surgical. This is another case of tumors of the lateral ventricle. This is a male of 48 years old with conduct disorders, hydrocephalus, and this lesion attached to the ventricular septum. This is the largest tumor we operate and remove completely with endoscopic techniques. It was 7 centimeters for 5 centimeters. What did we do? With coagulation, and we cut slices of the tumor and remove in parts the lesion until we remove it completely. This is the patient the day after the operation, and this is the patient 7 years after the operation, without symptoms and without tumor. It was a subependymoma. The third ventricular tumors, we will divide them in anterior third ventricular tumors and posterior. This is a young lady with a biventricular hydrocephalus and a cystic lesion of the wall of the third ventricle. We approach, this is foramen Monro. This is the area of the tumor. We make an incision in the ependymal wall and open the cyst. Aspirate the contents of the cyst and inspect the cavity. This is inside the cyst, the cystic cavity, and you will see in this area a pathological tissue that will be removed. And that was the evidence of a pilocytic astrocytoma. The patient was discharged from the hospital 48 hours after the operation, and this is the MRI 60 days after the operation. The cyst did not collapse completely. This is our approach to the cyst, but the hydrocephalus improved, and she's today very good. This is another case of tumors of the anterior third ventricle. It's a female, 70 years old, with a colic cyst known from 20 years ago, but her neurology didn't allow the neurosurgeon to operate it. And in this case, we have been lucky and could operate this patient. This is the approach. The septum interventricular doesn't exist because long-term hydrocephalus. Coagulation of choroid plexus and the cyst wall. Aspiration of the contents of the cyst. And removal of the capsula. The capsula was rather soft, so It's difficult to take it with the forceps, and when we were taking it out, we lost it, and the capsule went to the occipital horn of the lateral ventricle. This is a catheter of the shunt she had. There is the capsula that we could remove it. This time successfully. And this is the inspection of the third ventricle. This is another case of colloid cyst. This is a male of 42 years old with a colloid cyst who had an attempt of microsurgical resection without success in another hospital, and you see the lesions he had. Look at this image, please. We approached with the endoscope. Foramen Monro was free. There was no tumor. And the tumor was inside the septum interventricular here. We open the septum. And this is the contents of the cyst that is removed. And this is the end of the operation. Here you can see the cavity without cyst. Tumors of the posterior third ventricle usually are tumors of the pineal region. This case is a female of 35 years old with rhinolichorrhea. She went to another hospital and to the ANT section, and they make a pedicle septal flap to close the rhinolichorrhea. In the same day, the patient developed an acute hydrocephalus and became comatose. In the CT, there was a pineal calcified pineal region lesion. So they performed an external ventricular drainage, and in the other morning, we went to that hospital to make a third ventriculostomy and biopsy of the tumor. Third ventriculostomy in the usual, with the usual technique, with no problems. And in the same operation, we made a biopsy of the tumor that has been a pineocytoma. The patient didn't want to be operated. She's many years she's very good. She had another child. She was get pregnant and is very good of health. About posterior fossa tumors are difficult to remove with endoscopic techniques, except for cysticercos that Tenor will talk about that. But usually they are related with hydrocephalus. The problem with the third ventriculostomy in these tumors is that the tumor and the pressure of the posterior fossa causes a distortion of the cistern and the floor of the third ventricle. This is the approach, the normal approach for third ventriculostomy. You approach the floor nearly in perpendicular direction, but where is a tumor, the distortion of the cistern make that you must approach it tangentially. And more, the pressure with of the posterior fossa can cause some other effects, as in this case. This is a posterior fossa tumor with hydrocephalus, and her doctor asked us before the remotion of the tumor to make a third ventriculostomy. This is not a contraindication of third ventriculostomy in posterior fossa tumors, but you must be very, very you must think that the arteries and the nerves are closely attached to the floor of the ventricle. So when you make third ventriculostomy, it's more possible to damage arteries or nerves. This must be taken in account to avoid complications. And this is all. Thank you very much.
Thank you very much, Carlos. It was clear, and I think it's seeing you going into the posterior fossa, getting those biopsies done. It's always encouraging, because we are quite comfortable to make sure that this drainage of CSF continues. And in our setup in Africa, we are so keen on not losing people to follow up. So endoscopic third ventriculostomy is actually a backbone of how all these things are done. So thanks very much for that.
Yes, you must think all the things are attached to the floor of third ventricle. It's not a contraindication. You must be very, very awake to avoid complication, nothing else. And never use, of course, coagulation or laser to open third ventricle, the floor of third ventricle.
Thank you. Sandra, anything you want to add on that, or Moody?
No, I think he's covered quite a lot of lesions here, and I think we can probably proceed to the next talk.
Excellent.
I think the valuable lesson that he has provided towards the end is very useful for young neurosurgeons going into endoscopy, that you've got a fourth ventricular lesion with hydrocephalus. Whilst doing the ETV, just be very aware that some of that distortions might happen in the basal cistern. So I think that was a very useful tip that he's provided for us. Thank you, Gagliardo.
Excellent. Now we have Teno Herrera from Mexico to tell us about management of intraventricular cysticercosis. And of course, cysticercosis is something which we see out here in Kenya, but it's always frightening when you hear about all the complications that do arise with these things bursting and so on and so forth. And when you see the lesions themselves with the daughter cysts, it looks very beautiful, but it can be very treacherous. So Teno, the floor is yours for you to tell us about the management of intraventricular cysticercosis.
Thank you. Carlos, could you please stop sharing your screen so I can
Yes,
Chairman.
I'm trying to.
Thank you. Good morning, and thank you to the World Federation and the organizers of this webinar for inviting me this morning to speak to you about the endoscopic treatment of neurocystic sarcosis. As you know, neurocystic sarcosis is the most frequent parasitic infestation of the central nervous system. And
I can want to understand you much better if I can.
excuse me? Okay, is the most frequent parasitic infestation of the central nervous system, and Taenia solium is a tapeworm that parasites the human bowel. Man contracts cysticercosis with the ingestion of food or water contaminated with stools containing eggs of Taenia solium. The cysticercosis has many forms in the central nervous system. It can be intraparenchymatous, subarachnoid, or intraventricular. The cysticercosis has two main parts, the vesicular wall and the scolex. After the cysticercoid enters the nervous system, it enters a vesicular viable stage where it has a translucent membrane and a head, which is the scolex. The cysticercosis may be viable for many years. So we have several forms of treatment in the including medical treatment with albendazole, which is reserved for parenchymatous forms and those without mass effect. The use of medication in the treatment of subarachnoid or intraventricular forms can lead to arachnoiditis due to rupture of the cyst contents into the intraventricular or the subarachnoid space. And there is surgical treatment. Neuroendoscopy in the last years is the election treatment for some forms of intraventricular and subarachnoid cysticercosis, as I will show you in the next minutes. This is the endoscope we use. This is a rigid endoscope. We do not have experience with fiber scope or flexible endoscopy. And we have an endoscope with one working channel, one irrigation, and one suction channel. We also use, whenever is possible in Mexico, the help of neuronavigation systems. And I will show you some examples. In this case, we have a patient with a frontal cyst, as you can see here in the MRI. And we decided to enter via a frontal trajectory into the intraventricular space. Here, as you can see, we will start with the approach. And once we get into the ventricle, we found immediately the cyst. So with the tip of the endoscope, we start dissecting or detaching the cyst from the ventricular wall. And once we inspected well the surroundings of the ventricular walls, we saw there was no firm adhesion. We choose to aspire the cyst. We apply suction to the to the aspiration channel, and we attach the tip of the endoscope to the cyst, so we could aspire the cyst. In this case, we start pulling the cyst with the wall sheet of the endoscope, and we took out the cyst completely, as you can see here. And once we finish the aspiration, we go back into the ventricle in order to inspect that there are no bleeding, as we can see here, and there is no other lesions. Usually we perform an septostomy
in order to communicate both ventricles, because there is, as you can see here, a very severe inflammatory response into the ependyma. So to avoid the formation of septums or asymmetrical hydrocephalus, we perform the septostomy and communicate the complete ventricular system. As you can see here, the aspect of the ventricular wall is not normal. There is what we call the granular arachnoiditis, which is the inflammatory response of the ventricular system to the neurocysticercosis. And here is the postoperative MRI with no hydrocephalus and no rest of cysticercosis. In this other case, we have a patient with a lot of subarachnoid with hydrocephalus and subarachnoid cysts, as you can see here in the prepontine cisterns and the both cerebellopontine angles. So we decided to go in with the endoscopic third ventriculostomy and try to take the cysts from the subarachnoid space. In these cases, in which there is inflammatory response in the ventricular wall, to perforate the third ventricle, the floor of the third ventricle, it's a little bit more difficult because it's very, very stiff, very rigid. So we do this instead of the balloon catheter. First, we do the perforation with a blunt probe, and then we get into the ventricle with the balloon catheter and initiate the dilatation, as we can see here. Once we do the dilatation of the stoma in the floor of the third ventricle, we proceed to advance the tip of the endoscope into the subarachnoid space. And in this case, we found many cysticercocysts, and you will see in the next minutes. And you can see we can detach the cysts from the very carefully inspection of the subarachnoid space. Here, there is a cyst right there, and we start detaching and pulling out the cysts with the biopsy forceps. And here we have the forceps, and we took out the cysts one by one. Sometimes the cyst will not fit into the working channel, so we need to take the cyst with the whole endoscope, and then we go in again, like in this case. Now we are returning to the subarachnoid space. You can see here there is one cyst, another cyst. Here are the arteries, the clivus, and we are taking all the cysts until the cistern is completely free. In this other case, we see this MRI in which this patient had hydrocephalus and resembled the MRI third ventricular colloid cyst. And what we found was this lesion that was floating freely in the third ventricle. Here we can see the normal anatomy, the choroid plexus, the veins, and here at the bottom of the third ventricle, we can see the cyst. So we start pulling the cyst. Sometimes the cyst will broke. In this case, it's necessary to irrigate with a lot of Bringer solution in order to avoid the chemical arachnoiditis. So we took the cyst, we inspected back, and we see the inflammatory response. However, in this case, was not necessary to perform an endoscopic third ventriculostomy, since we considered the cyst was the cause of the hydrocephalus. This is the postoperative MRI. And finally, this is very frequent here in Mexico, the fourth ventricular cyst, neurocysticercosis. And in this case, we decided to go to a transfrontal, transaqueductal route in order to take out the cyst. We decided far anterior perforation in order to approach the fourth ventricle through the aqueduct. So as you can see here, we got into the lateral ventricle, and now we can see here the anterior part of the third ventricle. And finally, if we pull back the tip of the endoscope, we will see the aqueduct, which in this case is quite dilated. So we can approach and introduce the tip of the endoscope into the third ventricle without causing any harm to the aqueduct. We can see here the cyst at the bottom of the aqueduct. So now first we introduce the tip of the forceps and try to grasp the cyst. In some cases, the cyst will rupture. So as I advised earlier, it's necessary to perform a lot of irrigation. In this case, we are inside the fourth ventricle. It's necessary to do very gentle movements with the endoscope in order not to damage the aqueduct. So we are pulling the cyst, and in this case, the cyst will rupture when we are trying to get it, because the scolex, or the head of the cyst, is not fitting, narrow enough to get into to fit into the aqueduct. So we are pulling in a very gentle way the cyst. We are seeing here how the contents of the cyst is coming out. So we are rinsing with a Ringer solution, a lot of solution, in order to avoid the arachnoiditis postoperative. In this case, also is necessary to give 1 or 2 doses of steroids to avoid the arachnoiditis. So this is the scolex, the head of the cyst. And here we are pulling out through the aqueduct, the foramen of Monroe, and the trajectory in the frontal lobe. And we are taking out the cyst. There are some membrane cysts. We need to take out all the membranes in order to not have an postoperative hydrocephalus. Here we're pulling completely the cyst. Here there are some parts of the scolex right there. And now we are taking out, and finally we took the complete cyst. As you can see in the next slide, you will see how is the cyst. Here we now go back and inspect the ventricle, the lateral ventricle, the aqueduct, and we see that there is no remains of the cyst. Here is the cyst. This is the vesicular wall and the scolex. So it's completely removed. And the postoperative MRI. Neuroendoscopy is the election treatment for the forms of intraventricular and some parts of subarachnoid cysticercosis. So we need to have in mind that this is a procedure that can be much less aggressive than the microsurgical techniques. And also we need to contemplate the medical treatment in the posterior days after the treatment of the surgical treatment of neurocysticercosis. Thank you very much.
Thank you, Teno. I must admit, having dealt with psychosis on an open method, where we are always very petrified about these things rupturing and how you'll have the remnants and so on, seedlings, to see you extract that from the fourth ventricle through the aqueduct is a real feat. But as you said, it's good to note that there's this as a possibility. But I know for the younger neurosurgeons who are listening, the dexterity required, you really have to start off making sure that you can do your endoscopic third ventriculostomy first before you start leaping into the fourth ventricle to remove the daughter cysts. Comments, Moody?
Yeah, I just wanted to ask you, Tanok, is there any recommended period that you advise starting albendazole before you operate, or it doesn't really matter, particularly with the possibility of the spread of the cysticercosis around the ventricles? Do you recommend that we start, or you start albendazole a few days before or at time of surgery, or it doesn't really matter?
Well, we start the treatment with the albendazole in the postoperative period, immediately in the postoperative period, because we consider that where there is an intraventricular cyst, we have the disease in all the parenchymal system. So it's in order to not to have another cyst developed lately, we decided to start the treatment of albendazole in the postoperative period. Not before, just right after the discharge of the patient. It's an ambulatory treatment.
If I understand correctly, Moody, the general feeling is, or what the medical treatment does is that it does not work on intraventricular cysticercosis. And that is one major reason why surgery is almost always necessary. And therefore, preoperative albendazole usually is not given. But there are two other questions which Samir has asked, and I wanted a little extension on that. How do you treat an intraoperative rupture? So I would just extend this question by saying that do you use any specific irrigation, addition to the irrigation, to prevent spread of the chemical inflammation or the meningitis or ventriculitis that can occur? That is number one. And number two is, do you do additional third ventriculostomy in these patients, and what are the indications?
Yes, I use the steroids for a period of 24 hours, and I do not use any additional additive to the irrigation, only ringer solution. And about the third ventriculostomy, if the patient has hydrocephalus, I try to do third ventriculostomy in all cases. However, as I pointed earlier, to perform third ventriculostomy in these patients, it's very difficult because the floor of the third ventricle is very stiff, and sometimes it's very difficult to perforate. And you don't know if the tip of the basilar artery it's attached to the floor of the third ventricle because of the basal arachnoiditis. So if you start pushing the floor of the third ventricle with the blunt end probe, and it's not going through, I abandon the procedure and I prefer to leave a shunt, because the perforation and of the tip of the basilar artery is described in this case, in this type of patients.
Thank you.
That's very interesting for me. I'm waiting since my whole life to have such a cyst in Germany, but we have never seen it. But is this curable, the disease? Can you cure a patient with this medication and surgery, or?
Yes, you can cure the patient with the medication mainly, and of course the measures of hygiene and you have clean water and clean management of the food.
Yeah,
But
okay.
you
But
can cure.
obviously, it's different to the hydite cyst. Huh? When you open this cyst, they say patient will die because that's everywhere. But in the cysticercosis, it's not a problem if the cyst is open.
No, it's not a problem. You just have to wash with a lot of solution, and you will not have any arachnoiditis reaction of the patient.
Has somebody of you had this hydite cyst?
I'm not.
I've had hydatid cyst, but not in the ventricle. I have myself operated on 3 patients of intraventricular cysticercus, but one of my colleagues had a very peculiar experience, and I think that is a warning. The cysticercus cyst can actually get dislodged either during surgery or just before surgery. So you need to have an immediate preoperative scan. One patient where the cyst was seen to be close to foramen of Monro was just not seen, and it had gone into the other ventricle, into the occipital horn. And once the cyst had actually gone into the fourth ventricle, by the time the patient was operated for a lateral ventricular cyst. So these kind of things can happen, and therefore you need to have a scan just before surgery.
Henry, we do see hydatid cysts, and it's not quite accurate to say that if you burst it, the patient will have a reaction and die. The worry is the spread of daughter cysts, and that is the main problem, rather than an anaphylaxis or anything like that. So no, you can. I mean, obviously, one wants to be careful with these cysts, and if, the ones that I have seen have been in the spine. And if you do end up opening them up, there isn't an anaphylactic reaction. It's just that the worry is that you then spread the daughter cyst, and there's a possibility of recurrence, which increases in that sort of scenario.
Okay, thanks.
Henry, that gives you a chance when COVID finishes to go down to Siteno and let you operate on some.
Yes. Yes, that would be a good idea.
It would be a good vacation.
Yeah, I miss traveling a lot now. Since March, no traveling. I just traveled 2 times in Germany for a course for ENT doctors for skull base. That's it.
Can you remind me what traveling means? It seems so long ago that we traveled, we've forgotten the experience.
Yes, exactly.
Yeah, I think there's a question by Harshad Parekh about if you put in a shunt after any of your patients, and I think Tenok, you answered that where you have a difficulty in getting the ETV. So I think that was answered. Excellent. I think we're
just an add-on to that. Tenok, have you ever seen a situation where you have put in a shunt and then later developed peritoneal cysticercosis?
No, we haven't had seen that. We have seen the situation in which the tip of the ventricular catheter got obstructed by the cyst and is not functional. And when you withdraw the ventricular catheter during the shunt revision, you pull out the cyst of the ventricle attached to the tip of the ventricular catheter. But it's not, the cyst is too large in order to get into the tube and migrate to the peritoneal cavity. And very important is to understand in this case that the cyst in the cysticercosis is the final stage of the disease. And this is not a contagious cyst. If we rupture the cyst, this is not going to spread the disease. It's only to cause a chemical reaction into the surrounding structures. But we will not disseminate the disease. The cyst is not the mother of other cysts.
So the thinking is that the cyst is a reaction to the soleum?
It's the final stage of the tenuous soleum.
Okay, so it's almost like a reaction and then forms a cyst around it.
Yes.
Okay. Excellent. Thank you. We all continue to learn. Thank you very much.
Well, I think that kind of wrap things up. We've had a real jamboree of not only experiences from tumors to cysts. I think of all the things, especially for the trainees, anatomy is always and will be the mother of all directions in terms of what we do. Two, it's imperative that we all learn the roots, the techniques, and even if you don't have the up-to-date instruments, it is possible, being dexterous and slow and steady, to be able to do a lot of the things. So I think, as Henry started off with the Rolls Royce of all the instruments, left hand, right hand, by manual aspiration, and then you end up with one as angle scope, it is still a possible thing for us to be able to do. So I think we've all enjoyed ourselves, a lot of learning. Moody, any final comments?
No, I think from our side, I'd like to just thank the panelists and the speakers. It's been excellent that you could all make time for this special effort for young neurosurgeons across the globe. Thank you very much on behalf of the committee. Chandrasekhar, your final comments?
Thanks very much, all the speakers, the moderator. And I would just like to remind you, we'll be back 2 weeks later. We have to find out a better way that we can communicate and the participants can more actively participate in this kind of a program. And the next program is going to be the last session on intraventricular endoscopy with some solid tumors and complications being addressed. Thank you very much once again.
Okay, do you have a blessed day? Whatever, some people are starting early and some are finishing, and stay safe.
Yeah. It was good to see you all. Bye-bye. Take care and have a nice weekend.
Bye-bye.
I would
Thank
request
you.
all of you to join future programs as well. Your comments would be very appreciated.
Thank you. Thank you, Chacha.
Bye-bye.
Thank you, everyone. Thank you, and bye-bye. Thank you.
You're already taken off the weekend.
Thanks.
Okay, bye.
Bye, Carlos.
Bye. Bye, Chandra. Thank you. Thanks for all. Mohammed?